the plasticity of the brain is amazing.
Yeah.
And it can accommodate to the new sound. But the brain within, 3 months to a year then adapts this new sound. And then it connects the sound of a bird, that memory, with the sound of the cochlear implant. Because there is memory of that sound encoded in your brain. And it's just making that connection that happens.
Hello, this is Anthony Effinger. I'm the host of the Think Neuro podcast at Pacific Neuroscience Institute. And today I have two guests to talk about some really interesting things having to do with cochlear implants and cognition and a lot of other things. And I'm here with Dr. Chester Griffiths and Dr. Courtney Volker. Thanks for joining me.
Thank you.
So how about we start with just give us a bio. What attracted you to the field you're in and how you're working together?
Well, so this is my 37th year in practice after training. I was interested in the field of otolaryngology, head neck surgery, mainly because of the anatomy.
But you just used the big word there. Otolaryngology, right?
Otorhinolaryngology.
Otorhinolaryngology. So I'm hearing
Ear, nose, and throat.
ear, nose, and yeah.
And head neck surgery. So
Yep.
basically, it's a specialty dictated by the cranial nerves and above anything above the clavicle.
Is that what unifies all that?
Yes.
I never knew that.
Yeah.
Okay, thank you.
So the anatomy always really interests me and the complexity of it. But then when I was doing my medical school rotations, I saw some of the surgical procedures. I actually saw a face-off procedure in which they removed a very large tumor and then put the face back as if nothing happened.
You're talking, when you say face off, you mean?
Literally lifting all the skin, disjoining it from the skeleton, and then removing the tumor and then putting it back as if nothing happened. Wow. As you say, wow, that as a medical student, I said, that's what I want to do. And here I am now, almost 40 years later, doing.
I'm not sure that would have been my reaction.
But it fascinated
That's
me,
amazing, yeah.
that you could do that amount of surgery and really have no signs. And that parlays into one of the mantras of the Pacific Neuroscience Institute, which is minimally invasive keyhole surgery, where, we will remove a 4-centimeter brain tumor through the nose. There's no incisions on the outside, and the patient goes home in 3 days. And they have to then convince people that they had brain surgery because nobody believes them.
Good problem to have.
Good problem to have. But that kind of was the genesis of what got me interested in. And then myself, Dr. Kelly, Dr. Krause, and Dr. Kestry got together. And we really wanted, in the kind of the twilights of our careers, create a really the essence of being a physician and being patient-centric, being academically curious, and really being a doctor, and really a community service-oriented group. And so we launched the P&I to take the promise into practice, meaning the promise of an academic center like UCLA or USC being all the great services and disciplines and intellects and research, along with patient care, but taking that promise and really putting it into practice. And that's really what the Pacific Neuroscience Institute is. And then because of that, we've recruited brilliant faculty from all over the country, and just superlative people and scientists and academicians. But really, that wasn't our main focus. The focus was in their humanity and their personality. They had already checked all the boxes. And we really wanted to find those people that were not only brilliant and scientifically curious, but really had a real ability to take care of patients and be humans and have that humanistic side. And Dr. Volker is a great example of that. She's brilliant. She's surgically, I'd let her operate on me. And that's sort of one of the tests. You know, if I would allow a surgeon to operate on me, I'd tell patients, I think it's okay for you.
Is that part of the job application process? You have to do some procedure on somebody here?
No, but I've known of her reputation, and it's only come in spades, even more so since she's been here. But that really was the what enthused me to be here at Pacific Neuroscience Institute and be one of the founders, and it still motivates me every day. We have a phenomenal group. We do great things for people, for our community, and for the advancement of the science. So, what more would you want?
Yeah, you know, as a journalist, and I think I can be, you know, pretty unbiased here. But having met a lot of you, the one thing among many things I say about PNI is, first thing I mentioned is the culture. And I've seen a lot of cultures in my life covering business, and it's something that people, they toss the word around and they usually get it wrong. You really do have quite the culture here. I'm going to say that on the record. It's amazing. So, and now I kind of know why, because it's a huge priority.
It was
right?
our number one priority.
Yeah, humanity.
You know, so many patients will comment, and people will comment that doctors have lost that way. Mm-hmm. And we all went to medical school and really made a dedication of our lives to this, to take care of people, to take care of people. And the whole process has sort of lost its way a little bit. But we, the founders, really wanted to get back into the huddle and get back to the core purpose of why did all of us go to medical school? And if you ask physicians why they did, it was because of that real priority to take care of people.
Yeah. Dr. Volker?
So my whole career has been in academics, and I was approached by Dr. Griffiths to really join the special group, a multidisciplinary group, really organized under an umbrella of brain health. And this intrigued me. It was a group of academically minded folks that's multidisciplinary, and I was recruited with my role as the connection between hearing and cognition of the brain. So we know that hearing loss is the number one modifiable risk factor to cognitive decline. And when hearing loss is not treated maximally, either through hearing aids or cochlear implants, that the cognition of the brain starts to decline. And it's a travesty because this is something that can be treated.
I watched this happen in my mother.
Yes.
Totally.
And so my role was to bring this technology out into the community, out into the populace, rather than being trapped in the academic center that's very difficult for many people to navigate and to get through.
To get to a doctor.
To get through the parking, to get an appointment, to get someone to answer the phone. There's so many obstacles.
In an academic medical setting?
Medical center, big academic
Okay.
centers.
Okay.
We lose patients. We lose patients that don't want to be a burden on their family, that needs to take off of work. And so I had the opportunity, along with Dr. Lewis, my cochlear implant audiologist, to start a community-based cochlear implant program from scratch. So our goal was to really dive deeply into how we can make the process for a patient seamless and efficient, so that when we get a referral, we can get the patient in quickly, minimize the number of appointments, get them implanted, and get them programmed quickly.
So tell us quickly, I love these devices are magical. A cochlear implant is truly magical. Can you tell us how you do it, how you implant one, and just the parts and how they work?
Yeah.
It's fascinating.
So it's an outpatient procedure. The patient comes in the same day, goes home the same day. It's about a 2 to 3 hour procedure. I make a small incision behind the ear. I make a little pocket under the chewing muscle to place the internal device. And then I make a small window into the cochlea, insert the electrode, and then sew up the incision.
So you're not drilling into bone or any of that, or are you?
I do.
Okay.
So I drill the mastoid bone
Okay,
behind
right.
here, and I approach the cochlea, which is quite deep into the temporal bone.
It's in the bone?
It's in the bone.
Okay. So you tell us about how the cochlea works.
So the difference between hearing aids and cochlear implants, hearing aids go through the ear canal and they amplify the natural sound process. So they will amplify the conduction of the eardrum, 3 little ear bones into the cochlear hair cells and then along the nerve to the brain. What a cochlear implant does is it bypasses the hair cells of the cochlea, which are usually the trouble, and gives.
How big are those?
They're microscopic.
Microscopic.
Millions of hair cells within the cochlea.
And they're creating this action potential, or
Correct. They are vibrating
Yeah.
and sending action potential signals to the neurons that then go along the nerve.
So this is where we go from analog to digital,
Yeah.
kind of.
Correct.
Okay. Into
And you have
electricity.
24,000 frequencies. 24,000 frequencies
That the
That's-
cochlea can pick up.
that the cochlea can pick up. That's correct.
Yeah, this is just an amazing machine.
But the audible, your conscious range is anywhere from 12 to 14,000. Your subconscious is being stimulated by other,
Oh, my.
other stimuli.
that explains a few things.
Yes.
That's fascinating. So it's over powered, kind of, right? Compared to the brain, then?
Well, it's not. I wouldn't say it's overpowered, but I call it the magical organ because, as Helen Keller would say, if she were to choose, she'd rather be blind than deaf because blindness separates you from things, deafness separates you from nature and people, and because you hear so much more than you can see.
Yes.
And it's such an interesting, just to kind of expand on Dr. Volker's thought about how people kind of allow themselves to lose hearing. If you were to say to someone that is nearly blind, maybe have macular degeneration, that they could have a procedure where they would get their eyesight back, they would jump at it in a minute, in a millisecond. But then when you tell people, you're profoundly hard of hearing, but there's a procedure where you can get your hearing back. No, they don't.
See, this is, yeah.
Which is such an interesting disconnect. And one of the, when we were starting out and launching this program, which is called the Hearing Restoration Project, not only in cochlear implants, but in community awareness for physicians so that they can counsel their patients, but also with hearing aids and lip reading and assisted devices, anything that will help restore hearing. The fascinating thing is that blindness is such a societal mark in that the person that has blindness is then identified. They have a cane. They have dark glasses. They have a dog. So people see that and they immediately have a reflexive sensibility, compassion. I don't want that. Oh my gosh.
Oh, yeah.
But people with hearing loss are inapparent. People don't see hearing loss. And so it's really, in society, it's almost like a bastard sense. I mean, people don't see it, they don't know it, and it's truly a silent disease. And people, it's silent. They don't hear, and people don't know. So there is a total disconnect in society related to hearing loss. And as Dr. Volker was saying, it's probably one of the few ailments that the patient is blamed for their disease, which is really
Through
shocking.
impatience and...
Yeah, their family. Mom, where are your hearing aids? Mom, why aren't you
I know.
doing that? And they can't, the hearing aid is not working. And they put them on. It's almost worse.
To make it work.
I saw this. I saw this firsthand.
And so then, they don't want to upset their family members.
And they go silent.
And they go silent.
And
Yeah.
they get depressed.
Yeah. Yeah.
And they turn inward
Yeah.
and withdrawn.
That's why I think it's so fascinating that, it makes so much sense for P&I to go this direction, because you really are serious about brain health and cognition. And this is crucial, right? I mean,
And the community-based aspect,
Yeah.
of it, truly the community-based aspect. As a referring doctor to the centers, the academic centers, patients would come back and they would be dissuaded from doing it, or it would be a 6 to 8 month waiting list to get in, and then they would lose interest. There was too many physical barriers and psychological barriers. So we wanted to really break that down and make it more accessible, increase the access.
yeah, because as I understand that was limited for so long, right? There's all these, you couldn't get them until a certain age. You could only get one. Is that right? And that's changing.
Changes.
Yes.
Okay. So I just want you to finish. I just want to know how you get this little wire into the cochlea and what that's like. And then I want you guys to talk about how, why access is changing. And because this seems like a technology that should be really out there and popular and used, but it hasn't been, right, so far, because of these conceptions, I imagine. So just give me the details on the.
Okay. So I use small diamond drill bits, ranging anywhere from 0.5 millimeters to 5 millimeters. It's a very small anatomic space,
Yeah.
but done safely. And the patient can go home. I see the patient 1 week after the surgery just to check their incision, make sure everything's healing right. And then Dr. Lewis will activate them.
Yeah.
And-
But how do you just use the little drill and then you run how big is the wire?
The wire
is that the right word for it?
fractions of, the wire, we're talking millimeters. All of these dimensions are millimeters. So it's literally threaded into the cochlea. The cochlea is shaped like a conch shell. It has 2.5 turns, and it's inserted slowly and carefully.
How are you guiding it? Are you using any
I use a
imaging?
microscope.
Okay.
And through the microscope, I can see. Image guidance is not necessary. The threading of
You
the
can see
cochlea
this.
can.
So you got a microscope in the
Yes. And,
cavity there.
And if you just follow the anatomic landmarks and navigate your way towards the cochlea.
The amazing thing of why patients come back and say their hearing is actually better than even their best hearing with a hearing aid. A hearing aid amplifies sound in a very narrow bandwidth. When it gets very high frequency or low frequency, it just creates too much distortion. Whereas a cochlear implant has channels that amplify or stimulate the entire nerve. So it's bypassing these degenerative hair cells and going straight to stimulating the nerve. And so the bandwidth of hearing stimulation increases.
And the clarity.
And the
sound.
clarity of sound. It's not, all scratchy. And patients that have it on one side and have a hearing aid on the other will comment to us that their hearing is so much better on their cochlear implant side than on the hear. And they ask, well, can I get one on this side? Well, right now they only will cover one side.
That's an insurance issue?
That's an insurance issue. But
Okay.
Sometimes if the hearing loss gets really bad on that side, we can push that needle forward. But it's really it is a uniformly just a win-win for the patients and their families.
Well, as I said, I've seen this. It sounds like the hearing aid can be like a scratchy old record,
Yes.
whereas the cochlear implant is digital, CD quality, Blu-ray, whatever. I mean, that's video, but CD quality digital, right?
Yeah.
Is that the appropriate analogy?
And Dr. Boku can comment on this further, but it's never like natural sound.
Right.
But the brain, the plasticity of the brain is amazing.
Yeah.
And it can accommodate to the new sound. We're spoiled with sound for 60, 70, 80 years, natural sound. But the brain within, 3 months to a year then adapts this new sound. And then it connects the sound of a bird that memory with the sound of the cochlear implant, because there is memory of that sound encoded in your brain. And it's just making that connection that happens.
You said to invoke it again in a
Yes.
way.
Yes.
Wow.
And so, and that happens.
Just like you need rehab for a new knee or a new hip. I tell patients, you're going to need rehab when you get your new implant, just like you need a knee, physical therapy for your knee.
Yeah.
So we have a rehab program after patients get the surgery. We have a person on our team, Matilda, who has implants, and she's leading groups to help folks after surgery learn how to use their new implant in groups. That brings people out of their isolation, that brings people together to learn together. And this is wonderful.
How unusual is what you're doing in terms of trying to get this technology into the community?
So
I mean, are we still looking at big centers doing this elsewhere?
So this is the needle of getting folks implanted who need an implant has not moved for a decade. So only 5 to 7% of people who would benefit from a cochlear implant actually receive one. So that number is just terrible. So we can only do better. The problem is multifaceted, but one of the major barriers is bringing this technology out into the community. There's a huge bottleneck at academic centers. Also getting the word out in podcasts like this directly to the patients. So the patients can take it upon themselves to self-refer. I tell folks, if you are a patient that has a hearing aid that has been properly programmed and you're not doing well with it, that's all you need to know. You should be evaluated for this technology. So families can self-refer. We are talking to audiology groups about when to refer. We're talking to primary care doctors and neurologists, and any avenue. There are multiple barriers to people coming to us.
The technology has gotten so much better, right? You are on the technology curve, like, everything else, right? But to a degree, technology has really come to bear in this field. Has cost fallen? Is that something that helps you get this out into the community? Or
cost has not fallen.
It hasn't.
However, coverage by insurance and Medicare is improving.
Because they're getting with the program and seeing how important this is.
Correct.
And Medicare patients, it is a covered benefit. So there is no out-of-pocket for them.
It's free.
That's amazing. How long has that been the case?
It got approved probably 15, 18 years ago. So a lot of people are dissuaded because, the cost of this must be very expensive. But actually, for Medicare patients, if you meet the guidelines, then it is a covered benefit.
What are the guidelines?
So the guidelines are always changing.
Yeah, I
and
figured.
the reason for that, so when I was being trained, a person would have to be profoundly deaf in both ears. But now the needle is changing. For instance, P&I is a site for the expanded criteria research to really show how different patterns of hearing loss that aren't doing well with hearing aids benefit from cochlear implants. So what the covered criteria was last year may not be the covered criteria this year because so many people benefit from this technology.
And don't so many people head off cognitive problems?
Yes.
Like make this investment now and maybe we don't have to make a bigger investment later, right?
So when I was being trained, if any patient had any cognitive issues, we weren't enthusiastic about implanting that patient. And the thought was that their brain wouldn't be able to handle the input of the new technology. But actually, the ideas are changing because those are the exact patients where we can not only intervene with their hearing improvement, but those are the patients that, and we'll talk about the studies we're doing at P&I with the brain health team, those are the exact patients with mild cognitive decline where we could possibly reverse their cognition to actually improve the cognition. Now, if someone is so far down dementia scale, that they're really, in the end of dementia, that's not going to be a good candidate. However, the folks that are having early mild cognitive decline, those are exactly the patients that need to have this intervention.
It makes perfect sense, right? You're plugging them back into the world, right?
Exactly.
And you're stimulating, the inner ear is a very fascinating sensory neurobiologic structure. It's the first sensory organ that starts working
In utero, right? Yeah.
in utero. It's the last one that stops working after you pass. It's the one sensory organ, probably aside from smell, that is working 24 hours a day, 365 days a year. So it really is such a innately important sensory organ. To answer your question about the indications, it's 60 decibel hearing loss and a 60% word recognition. If you're at that level of hearing loss, so in other words, you're only understanding 6 of 10 words, and you have to increase the volume of the hearing aid up to 60 decibels to get stimulation, those patients are now candidates for a cochlear implant.
Okay.
Which really, what those indications, you don't want to get to the point where the organ in the brain has deteriorated so much. You want to get them in the mid-level so that you can rehabilitate them. And that's where we then integrated the Celebrate program.
Okay, talk about that.
So Celebrate is bringing all the avenues and the resources of the brain health team together with the cochlear implant program. So not only restoring the hearing, but then with that, doing cognitive fitness, brain nutrition, visual rehabilitation, olfactory rehabilitation, psychologic rehabilitation, and even community re-engagement. And because those are all of the natural things to get the brain working again and really replanting that patient back into their normal daily activities.
Yeah.
Because really hearing loss really extracts them from their normal daily activities. They don't want to go to group meetings. They don't want to go to family events. They don't want to go to the market. And then they become more and more isolated. And what that does, it just is exponential in the dementia range. And the quality of life, the joy of the bear. So having said that, we've launched a research program to see how all of those interventions, along with the cochlear implant, how that impacts brain health and cognitive decline. And really also looking at another lane parallel is how does it impact the caregivers, the families, the social environment? No one has studied that yet. And we're studying that as another arm of this project. Intuitively, you say that's going to help dramatically. But once you really show the family dynamics and the improvement in that, then it's going to bring it full circle. And people are going to really, I think, intuitively adopt this.
I think that's absolutely right. When you talked about research, is this what you're referring to?
Yeah.
Okay.
So we are identifying our patients in our cohort that have mild cognitive decline. And we are having 2 arms. One of the arms are the folks that would like to go through our Celebrate Brain Health program.
Celebrate's not an acronym, is it?
It
Yes,
is an
it is.
acronym.
It is?
Yes,
That's a long acronym.
it's a long acronym. Would you like to share it?
So cognitive enhancement, lifestyle engagement, brain rehabilitation, training, cognitive fitness, audiovisual, olfactory rehabilitation, and is eating healthy gut, healthy nutrition.
Wow.
So
Okay.
that- so-
all right. I like it.
So
We're going to quiz
you
you.
did
at
it.
the end of
You
the-
did it. Okay.
The
So-
podcast.
So in this process, the patient would then be set up to have monthly engagements with our brain health team in this. So they'll be doing the cognitive fitness rehab and
Brain gym stuff?
exactly,
Okay.
brain gym,
Yep.
all of that, as well as psychologic assistance on what is really bothering them, what are some solutions for that, et cetera, as well as getting their hearing back. And so hopefully that will re-energize them back into the joy of the bear.
Completely. Yeah.
And our scientific questions are really twofold. How does the cochlear implant improve cognition? And then the opposite. How does improving brain health help the patient use their cochlear implant better? Meaning, once we improve brain health on the receiving end, do those patients do better with their cochlear implant? And no one's asking that question.
Right. Because you'd want to kind of bring them both up
Correct.
together, right?
So most centers are just putting the implant in and on the way they go. But what if by improving all the brain health on the receiving end, those folks actually benefit more from this technology, or rather, the technology is working better and offering more assistance to that more healthy brain.
There's an integration. It's not
Integration.
happening if you just do the device.
Somewhat
right?
helpful, always helpful, right?
Yeah, right.
Always helpful.
Right.
But could we be doing more? Can the patient benefit even more?
And why wouldn't you?
That's our question.
I mean, you're leveraging the technology with this behavioral work,
That's a great
right?
way.
And that's probably
that's a great way
less
to
expensive
say it.
too. I mean, you're getting,
And, in medicine, I guess you could say there has been a paradigm shift in the approach of when doctors advise a treatment. Before, we would advise things based on the disease and our issues. How long can I get you to live? What is the improvement or the statistics of a particular treatment? The paradigm is shifting really to what matters to the patient. What is their quality of life? What is the impact of the treatment going to have on them? So you can imagine if we have a cancer, for example, and the life expectancy is 2 years, but the treatment is very burdensome and toxic to that patient. What matters to that patient? Would it be that they would rather forego the treatment and really enjoy the last 2 years without that burden? That's really the change. So it's really quality of life driven healthcare recommendations. And that's a complete paradigm shift. It really is coming into the humanistic aspect of medicine. Having said that, the quality of life is everything in the hearing restoration and brain health program. It's everything. Quality of life. It's not quantity of life. If there's no quality,
why?
Why?
It's like Peter Attia, the nutritionist doctor / he talks about good years, get the good years. And this is,
And hearing, and with Dr. Volker's and Dr. Lewis's amazing program, we're actually able to offer that advent to patients that they can get hearing back. And that's as Dr. Rose, it's the only sensory organ that has a mechanical technological solution.
Yeah.
You don't have an electronic eye. You don't have yet electronic hands.
Taste
but
buds.
You do.
Yeah, no.
None of that.
No. Tell me about what you've seen when you have somebody who has mild cognitive impairment and has hearing loss when they get a cochlear implant. When do you see it and what do you see?
One of my most magical activations that I saw was a Korean patriarch of the family who had completely withdrawn, doesn't speak a lot of English, high-powered attorney daughter, needs to take off of work to bring both parents in, be the translator, complete frustration and yelling within the
How old was the patriarch?
70s.
Ballpark? Okay.
Okay. But you can see he's the patriarch of the family, and yet it's humiliation for him to so proud of his first generation daughter. Here she is, a high powered attorney in Los Angeles. Every appointment has to come out of work in her business suit and her briefcase, and annoyed and frustrated, trying to translate in Korean everything I'm saying, plus telling them all to be quiet so she can listen to me. This dynamic.
You saw this. Yeah.
Preoperative appointments. His activation that involved all the members I just described was magical, because not only did his whole face light up, you could see his personality that I had never seen before. His daughter was smiling. They were clapping. They were laughing. He was repeating Korean words. And you could start to see the neuronal change within the brain right then and there. The cognitive changes as far as memory and, sharpness of cognition take time, right?
Sure.
But that is one good example of such a shift in such a short amount of
That
time.
must be amazing to see. You must feel like kind of a god.
So this particular activation, when the daughter was speaking Korean to her father and asking him to repeat the words, when he repeated the words perfectly after not hearing them, she started to cry.
Yeah.
I'm sure. I'm sure.
Yeah.
Wow. Did anybody get this on film?
Yes.
Oh, you did?
Yes. Yes.
That's terrific. Wow. Yeah, see, that's what we're talking about here, right? Now, he's back engaged. He can do more of the things he needs to do. She's freed up to be at work.
And he's back on the golf course sending us other Korean patients who also can't hear.
I mean, that's terrific.
Didn't he get the second set or
Not yet. Yeah.
Can he do that now?
Sure.
Yeah. Yeah. So there you go. I mean, look at, imagine the burden that's been lifted from his family. We can even start talking about economic growth here and, and cognitive problems avoided down the road, right?
Exactly.
I mean, isn't that what? Yeah. Yeah. Okay. So that's a terrific example. What about in really young patients?
All right. So in the pediatric world, we're doing better at identifying children that are deaf and hard of hearing. It's the federal law that when a child's born, before they leave the hospital, they must pass their newborn hearing screen. However, it's very overwhelming for a family. They're just given a piece of paper. Your child did not pass. Here are 3 places to go for the next step of verifying this. And some families fall off, and we lose track of those folks. Also, home births. Those home births do not oftentimes get their hearing tested. And then the parents are overwhelmed. It's on their to-do list, but that can oftentimes be lost. The second group of folks that we lose are when a baby is born with hearing, but gradually loses the hearing before age 5, when most schools test the children's hearing. So a common story in that age range is the mother is coming to the pediatrician, my boy is not talking. He's having a language delay. Oh, don't worry. Johnny will come along. No, that child needs to have their hearing tested. Let's make sure it's not the hearing. Let's remove that from the table and make sure that they're hearing. Once a child is identified and their hearing loss is verified through another specialized test, our center is very proud that we implant children immediately, even under the FDA guideline, if the patient's family is willing to sign and go off-label.
Is that what you need to do that? You just need parents' family's permission? And then
Yes.
Okay.
So I've been implanting children regularly as young as 5 months old. Once we verify their hearing loss, we get imaging to make sure they have hearing nerves, that they were born with a cochlea and anatomy that can receive the cochlea. And I'm proud to say that we are the first pediatric cochlear implants have been done in St. John's history through our PNI cochlear implant program.
That's terrific. That must be an even more difficult surgery on this very small.
Well, ironically, although the external ear and mastoid bone are smaller. You are born with an adult-sized cochlea.
I heard that. Yeah, that's fascinating. That doesn't that speak to the importance of this organ and sense? That's right.
It's an amazing organ in that it is located in the term median exact location in your head for balance, and it's in the hardest bone of the body, the otic capsule.
So it's protected.
It's protected.
Yeah.
And it's a membranous structure, but it doesn't change. Once you're born,
That's it.
that otic capsule is amorphous. It's doesn't change, and it's housing that so important organ.
That's amazing. I keep thinking about, they tell you to talk to your baby when you're pregnant. Legitimately, that's so
They can
important. They can hear, and we were, we did a lot of that. We talk a lot in our family. So, it's interesting. I mean, it's the more you learn, the more you want to know,
Right.
About this. At least I do.
Right. No, the inner ear is a magical organ, and I am. So you asked me what was my role. I'm the cheerleader of this program.
Okay.
Dr. Volker and Dr. Lewis are the brain trust of it and the skill trust. I'm just the guy on the sidelines with the pom-poms and trying to facilitate the program because it's so needed, and the experiences that we've had in restoring hearing to people with these cochlear implants really you understand why you're doing it, why you're getting out of bed every morning. And
It's immediately apparent.
it is magical.
Yeah.
And
There's some gratification. I mean, it's low hanging fruit, right?
Right. Well, in Los Angeles County, every year there's about 30,000 people that could qualify for a cochlear implant, and only about 600 are being implanted. That's
That's the travesty.
That's what you're trying to change.
that's what we're
That's what you're trying to change. Thank you so much for coming in.
Thank you.